In 1997, WHO classified obesity as a disease.
Is obesity on the rise in India?
Of course. And even childhood obesity right now. That's the scary part.
Obesity is a disease of the brain.
Right.
And the mouth gets zipped, then they dramatically lose weight.
70% of my clients are mostly women and 30% men.
And I wanted to ask you as a nutritionist, can you prescribe these drugs?
I am a doctor, so I could, but as a nutritionist, you cannot.
On the pen for Mounjaro, there's a red box there which says to be prescribed, taken under supervision of an endocrinologist or an internal medicine specialist.
Society does judge a lot more in India as compared to the Western world.
This is the danger of the popularity of these drugs. The downside is the misuse.
These drugs are a bridge. There's some people who can lose weight with lifestyle changes, and there's some people who need surgery.
Serena Williams, the fittest person in the world, just couldn't lose weight.
What are the benefits from taking these drugs?
Every time you're losing weight, you're losing some muscle.
If you're on a crash diet during which you lose a lot of muscle, you're not going to be able to keep that weight off.
Semaglutide, which we commonly know as Ozempic, is the first one that broke the 15% barrier.
I did read somewhere about blindness.
That can cause vision loss. The drugs will work only as long as you take them.
The world is divided into deciding whether it's a hero or a villain. Nobody understands that it's neither, it's just a tool.
After COVID-19, I think that one of the most talked about medical terms today is probably Ozempic and Mounjaro. They have become household names, so common that I think almost everyone feels like they know exactly what they are, or at least they think that they do. And that is where the danger lies. Because most people don't really understand what these drugs are doing to the body, who should be taking them, what the side effects are, and how or even they should be used safely and appropriately. Nearly 1 in 8 adults, which is about 12% in America, report that they've tried a GLP-1 drug, such as Ozempic or Mounjaro, for weight loss, and that trend is continuing into 2026. In India, sales of Mounjaro alone jumped from 13 crores in March to around 50 crores in just 3 months, which is showing a very strong early demand. So what started as medication for diabetes has entered the weight loss conversation, often without context, without guidance or understanding. And that's where things are getting tricky, because weight loss is never just, or shouldn't be just, about numbers on a scale, especially for women. It's about our hormones, about our health, sustainability, and a long-term impact. So today we're asking the questions that everyone is thinking, but that very few are answering properly. Initially, we really hoped to have a phenomenal woman speak with us, someone who's personally used Ozempic or Mounjaro for weight loss, someone who would share her lived experience. But the truth is that while many people are using these drugs, very few women are willing to share or talk about it openly. And that's exactly why we wanted to have this conversation today. Hello and welcome to All About Her, a space where we have honest and meaningful conversations about women's health, wellness, happiness, and self-care. And today we're discussing a favorite topic, Ozempic and Mounjaro. So we have two incredible guests joining us today. He is one of India's most respected voices in endocrinology, obesity, and diabetes care. As the chairman and head of endocrinology at Max Healthcare, his work has shaped how obesity and metabolic health are understood and how they're treated in India. He has been recognized with India's highest medical honors, including the Padma Bhushan and Dr. B.C. Roy Awards. We're honored to be joined today by Dr. Ambrish Mithal. Thank you so much.
Happy to be here.
And we also have someone who works very closely with individuals navigating weight loss, navigating nutrition, and long-term lifestyle changes. She helps people build sustainable habits, I think more than just quick fixes. As a nutritionist, she sees firsthand how medication and medications intersect with real lives, who benefits from them and who doesn't, and why food and behavior still remain so central to our health. I think her perspective bridges science with everyday reality, especially for women dealing with weight, with hormones, and with body image. Joining us is Dr. Juhi Agarwal. Thank you both for being here today. I'm so excited to have this conversation because whenever I go out and I meet people, you notice, in India especially, we notice people's appearances all the time. And normally you say, oh, you've lost weight, you put on weight. And we've noticed that a lot of people in the last couple of years have lost a lot of weight. And not everybody is telling us how. And normally, in this seat, we have somebody, not two experts like we have today, but we have someone who's had a personal journey with the issue that we're dealing with. It was hard to fill the chair with a woman who wanted to talk perhaps about losing weight through Ozempic and Mounjaro. And I understand why. But I do know that both of you treat a lot of people. And this is a medication, a drug that has become a household name. And the danger of that, I think something that is medical, becoming a household name, is that everybody has an opinion on it. But sometimes those opinions are not backed by real knowledge. And the idea today is to maybe have a sensible conversation about what these things are, what they do to our bodies, who are the right candidates for them, and whether they're safe or not. These are some of the questions that I wanted to ask the both of you. And I thought that I would ask because Dr. Mithal, you've written this lovely book, which is called The Weight Loss Revolution, and I read it. It's also easy to read because, as I said, it's not a very big book.
Not a tome.
It's not a tome, but it does highlight a lot of the things, but some people may not have read it. So for their benefit, I wanted to start by asking obesity. What exactly is obesity? It's become a rising concern in India. Of course, there was a time when being overweight was considered to be a sign of social status and health. Yeah. And, we look at paintings from the Middle Ages and, a lot of the people are quite full-figured. And this was something that people aspired to be. At some point, it became something that firstly, of course, was not attractive. And then I don't even know if people are thinking about the fact that the health issues that are linked to obesity. So can you enlighten us a little bit about exactly what is obesity and why some people become obese, even though they may be leading lifestyles that are similar to people who are not?
So I think that's a very good start. So we need to understand why obesity was regarded as healthy in the earlier ages. And the reason was that when there is a shortage of food, when there is deprivation, and people are undernourished and dying of undernutrition, then anyone who's overweight or has to be affluent,
yes,
that category. So it was something that people aspired for. But then obviously people realized that it doesn't lead anywhere, and then the concepts of beauty changed and development happened, especially in the Western world, and that's how it changed. At the moment, obesity is defined as excess adiposity. To put it simply, excess fat.
Right.
So excess fat in the body is called, you may call it overweight or obesity, but the problem is that the excess fat in the body that we look at cosmetically actually is the harbinger of a disease process. And this is not new. So in 1997, WHO classified obesity as a disease, 1997. So what's happened? I mean, as exactly as you're saying, everyone's talking about it. The thing is that we didn't have the tools to handle it. We had nothing to offer other than diet and lifestyle, which is still remains the keystone of treatment, but we didn't have anything other than that. So we have to think of obesity as excess fat that leads to what? Type 2 diabetes. Direct correlation. If you had a magic wand and you sort of waved it and you just abolished obesity, eradicated obesity, then diabetes would also disappear. Hypertension, heart disease, fatty liver, we all talk about fatty liver, some kinds of cholesterol problems, even some brain issues, even some cancers. So obesity, for modern non-communicable disease, obesity is the starting point. It's the mother of all NCDs, as we say. So that's why it is very important.
It's interesting because, again, in your book you talked about the fact that way back there was knowledge about the fact, even though we didn't have the ability to test in the way that we do today, there was a knowledge that things like infertility, things like sudden premature death were linked to being overweight. I wanted to ask you, Juhi, because as a nutritionist, of course, you come across so many people. Is obesity on the rise in India?
Of course. And even childhood obesity right now. I think that's the scary part. But it is, of course, on the rise right now. And actually, what we're seeing at the clinic is people who have, there's like this, let's say, thin fat obesity coming in, where women and men are thin, but internally they're fat. That means their visceral fat levels are higher and their body fat percentage is higher.
But you have to explain what visceral fat is.
So visceral fat is around all your organs, like around your liver. Fatty liver would be counted as like the fat around the liver, which is the visceral fat. Visceral organs are all the organs in the abdomen.
Right.
So the fat that is deposited there is actually one of the main culprits of all of these diseases that Dr. Mithal has just mentioned. And this comes from years, I mean, I would say like decades of people trying to lose weight.
Yes.
So we have a lot of women and men between 35 and 60 coming to us eating a lot lesser than they should. So they're not eating their meals nutritiously at all with the goal of losing weight. And what that actually does is if you're not balancing your nutrition, you're losing muscle mass.
Right.
So you're in this constant cycle of eating less protein, losing muscle, losing weight. But then when you go back to your normal eating habits, you're gaining fat because your nutrition has never been balanced. So you may be the same weight as you were 10 years ago, but the body composition has changed. That means your body fat percentage has gone up by about 5 to 10%.
Right.
And that is the real problem, I feel right now.
Right. Do you feel, Dr. Mithal, that people are understanding now that obesity is a health concern, or is the focus still that I don't look good and it's a cosmetic issue?
So the truth is that it's largely the latter, because people who approach us for weight loss, she would testify to that. For her, it'll probably be 100%.
Yeah.
For me also, it's pretty high. The proportion of people are only looking at cosmetics.
Yeah.
So the thing is that there is a fine balance here. So let me tell you, WHO called it a disease so many years ago, almost 30 years ago. The issue is that you don't want people to feel diseased.
Yes.
So I am a bit concerned about using obesity as a disease kind of thing. I see these advertisements. I mean, you can't, like, half of India is diseased. The people already struggling with so many things in their mind. Now you tell them you've got another disease because your BMI is a little high. So I think, but it is very important for people to understand that it's a health condition.
Right.
And when many times when we are talking of obesity and weight reduction, we are looking at something else, and the patient is looking at something else. So we do try to convince, but it doesn't matter so long as they are listening to us, it's all right. So long as they're on the path to weight reduction, it's all right. So I think we really have to understand obesity as, or even overweight, as a forerunner of so many disorders rather than pure cosmetics. And this is important. Important because not just a perception, but when you're trying to lose weight also, sometimes people want perfection, physical perfection, visual perfection.
Right.
Whereas for us, if someone loses 10% body weight, they've gained a huge health benefit.
Yes.
So we are very happy. This guy was 100 kilograms and now he's like 87.
Right.
Great result. I want to be, 70. It doesn't work like that.
Yes.
So that is why the concept is important, and I'm very glad you brought up the point of two important points which I will reiterate. That it is the toffee syndrome, thin outside, fat inside Indians.
It's called the toffee syndrome.
So which means that we look like we're body weight, if you go strictly by BMI is okay, but there's fat.
Yes.
So all fat is not the same. There is bad fat inside our abdomen as already or around our organs.
Yeah.
That is one. The other is, which is a big concern, and we'll come to that, with these medications also, the newer medications, is exactly what she said. If you lose weight and give up the medication, comes back, lose weight again, every time you're losing weight, you're losing some muscle.
Right.
Yeah.
And every time you're putting it back on, you're putting on predominantly fat.
Right.
So for few cycles of that, and
it's true. And of course, because of the drugs that we're going to talk about now, what happens is that you lose weight, and people have lost weight in the past, and these issues have arisen in terms of your body composition changing. So I will come to that. I wanted to ask, when you said obesity and the fact that most people see it as cosmetic, I wanted to ask you, Juhi, people come to you. Do more women come to you to lose weight? Do men come to you? Because,
women for sure. Women for sure.
My question being that appearances seem to be things that women are more preoccupied with. And I don't know. I mean, you can correct me if this is true or not. And that's why earlier when we were discussing also, a lot of men seem to be more comfortable discussing what they're doing to lose weight. women perhaps a little more guarded about these things for various reasons. But is it so? Most of your clients tend to be women.
I would say there would be a 70-30% split. So I think 70% of us, 70% of my clients are mostly women, and 30% men. Women also, I do believe, yes, society puts a lot of pressure on them, and they don't realize that, you know, we're going through different phases, right?
Yeah.
Women have, like, they go through puberty. There is pregnancy, marriage. There's pregnancy, post-pregnancy, perimenopause, menopause, and there's such a complex interplay of hormones.
Yeah.
And these hormones change on a monthly basis. I mean, daily basis, but yeah, there's like a cycle every month. So it changes how your body is metabolizing the food that you eat. Just to relate it back to weight and relate it back to nutrition.
Right.
So it is a lot more complex for women, and that's why I think we see also that 70% of the people who come to us are women for two reasons. One is because of the societal standards, and the second is because of the complex hormonal changes that make it difficult for them to lose weight.
Right.
Or like make them gain weight very quickly.
Right. And I want to come to all of that a little later in the discussion in terms of all those stages, predominantly because it's called All About Her in a woman's life, and how much of that can be addressed through medication and how much can be addressed through lifestyle. To perhaps take it to the beginning, Ozempic, Mounjaro, the GLP-1 drugs. Why, when were they created? I just want to ask also the difference between them for some people who may not know.
So these are GLP-1 drugs. GLP-1 is a natural body hormone.
Yes.
It's secreted in our body from our gut, and it goes to the pancreas to stimulate insulin secretion. So when we eat food, we need to metabolize it, so it goes to the pancreas to stimulate insulin secretion. It also goes to the stomach, the intestine itself, and there are receptors for that, and the stomach movement slows down gastric emptying. But a third point in that is that it also goes to the brain.
Yeah.
And there it impacts our appetite and satiation. So appetite and satiety both are impacted by this. So this is a natural body. So why can't we just use this hormone? Because if you give this hormone to anybody, it'll break down. Even if you give it via injection, it takes 2-3 minutes to break down.
Right.
So for 20 years, we've been using products derived or developed from this hormone to treat diabetes.
Right.
Because it stimulates insulin secretion, and even slowing of stomach emptying also helps sugar levels. But we always noticed that there is a reduction in appetite also, and people are losing some weight. So 3 kilograms, 4 kilograms, 5 kilograms. We published work on that. It's a well-established global fact. So scientists were really intrigued, and that's when the brain action was better understood as work kept going on in this direction. Amazing science, which is why I get excited about the science part of it. And they gradually developed molecules that will have a predominant action. They'll continue to have the glucose action and the other actions, but which will have you enhance the brain action.
Right.
And that is the GLP-1 like drugs, which predominant brain action, well, not predominant, that's wrong, with a stronger brain action.
Right.
And that is the change that has happened. So the drugs have been there, the predecessors have been there.
Right.
But semaglutide, which we commonly know as Ozempic, is the first one that broke the 15% barrier.
So 15%
15% like holy grail. You cross that because no tool had been able to do it. Yes, of weight loss. Of your starting baseline weight.
Yes.
Right. So that became big news all over the world, and also for us, for endocrinologists, for nutritionists, it's big news because you have suddenly got something that is able to do that, and 15%, 18%, 14%, but in that zone. So that became very exciting. So that shifted the focus a little bit, because once you're losing that much weight, you're getting more benefit in your diabetes, you're reducing your heart risk by 25%, you're reducing your kidney disease progression, you're squeezing out the fat from the liver, the fatty livers is melting away. So very exciting. But it caught the public eye because of the degree of weight loss, and people suddenly thought you could do that. And then that is GLP-1, that is semaglutide, also known as Ozempic or Wegovy.
But before you come to Mounjaro, I just wanted to ask you, the predominant effect that it's having, is it more that it is slowing down the emptying of the stomach, or is it more on the brain? Or do we know?
So when we talk of weight reduction as an effect, that is primarily to the brain.
Right. And
So-
you have said also in your book that weight and weight loss have a lot to do with the brain.
Yes, absolutely. Because obesity is a disease of the brain.
Right.
I'm sticking my neck out, but that's how it is.
Right.
Because some people's brains are wired in a way, there are neuroendocrine, neurohormonal changes that they have such intense cravings that genuinely, despite genuinely trying, they cannot control them. And
And
there
that
are
is-
people like that we meet every day.
Yeah.
So that is not,
It's very
for lack of a
difficult.
better word, it's not their fault.
Well, in some
It's-
sense it isn't,
yeah,
but you
yeah.
need discipline, of course,
Yeah.
but you can't take that away. But despite that, some people can't do it.
It's a challenge.
We call it food noise sometimes. Because, there are people who, when they land in a city, the first thing they'll be finding out is which are the good places to eat and where should we have.
Yes.
And the
Yeah.
other guy who's
Yeah.
traveling with them is probably saying, we'll manage
Yeah.
something, we'll do something.
Right.
So these drugs act at that level. That is the action of GLP-1,
Right.
semaglutide.
Right. And Mounjaro is different.
So Mounjaro is
Apart from being a little costlier, and you can lose a little bit more weight, is my understanding.
So, Mounjaro, by its actions, has, of course, GLP-1 is a central pathway. There's also another hormone called GIP, right? These are incretin hormones. So, it acts through both. So, it's, for us, again, it's quite remarkable that you have a single molecule that acts through two pathways. I
Right.
mean, that's
Right.
science-wise, again,
And the hope is for
fascinating.
it to
That's
act in
beautiful, yeah.
more pathways in the
Yes,
future.
now we already have those
Yeah.
molecules, studied and all. But Mounjaro is the one. So you get greater weight loss with Mounjaro. A little bit more.
So if Ozempic was 15%,
20.
20%,
Mounjaro is 20.
and Mounjaro is-
Ozempic 15%, Mounjaro
Mounjaro is
20%.
20%.
A broad figure. The important point is it does not always translate into greater health benefits.
right.
There are multiple factors that determine that. The
Right.
anti-inflammatory action of the molecule, so many things. So it may or may not be, we don't know yet. But for the public, for weight reduction per se, Mounjaro is a tad superior to semaglutide.
Gee. When did these words enter your universe?
I would say just at the tail end of COVID, so around 2022, because we have a lot of clients overseas as well. So I think in India it wasn't licensed or it wasn't in the guidelines as the plan of action for weight loss.
This
And
is,
it's-
sorry to interrupt you, but it was basically America and Denmark came up with these drugs?
Yes.
But
yes, these
yeah,
two.
These
yeah.
two.
So clients in the US, Dubai, a little like basically not India yet. That's when we started hearing of it and people asking us questions about should I go on it, should I not go on it? My doctors told me to go on it. What are going to be the side effects, etc. And I think in India it was a year and a half.
No, actually, not even a year.
Not even a year.
Not
Yeah.
even a year.
Yeah.
It's been
Yeah.
since it's come into the guidelines, right? To
Yeah, yeah,
use
yeah.
for weight
Yeah.
loss.
Yeah.
Earlier it was just for type 2 diabetes.
Right.
But yeah, so
How, I mean, maybe if you can give us a best case scenario of one of your patients, in terms of how much weight that they've lost and how long it took them to lose this weight.
So, I don't know if it's the best case scenario or not, but people who lost a lot of weight.
Yes.
There are some people who've lost amazing amounts of weight.
Yeah,
I think those were quite careless
yeah,
and they've tried a few times and given up. And now they're just all over the place.
yeah,
When they start this and their mouth gets zipped,
yeah,
then they dramatically lose weight.
right.
And that's a bit of an issue because such people shouldn't feel, and they do sometimes feel, that now we are on the medication. I don't want to do diet and exercise. That I've been doing all my life. It never worked.
Yeah,
So why should I do it now?
right,
If they come and tell me that, why should I do it now?
right.
Then it requires explanation and the reasons why diet and lifestyle will always, diet and exercise, sleep will always remain the common. And
base.
these drugs will also work much better.
Yes,
So I have had patients, for example, let's take a diabetic patient who, if I'm not wrong, lost about 30 kilograms
over.
over about a year. And all his anti-diabetic drugs were stopped. The insulin, everything. He was only on one of these drugs, just this.
Right,
And he was like really excited, and because everything is gone.
Yeah.
He's never seen and HbA1c, which is a measure of 3 months diabetes control, at below 8, and now it's 6.1, 5.9.
Right.
So that is one good example. I think the issue with him was also, I'll point out something. So he was very happy but also concerned about it. Of course, he had some nausea, and we'll talk about the side effects. But he said that the funniest part, he said, and it's strange and bothering me also, that I used to love my halwa and my kachori and my puris and all that and jalebi. I used to dream about that.
And made him happy.
And that is what I was looking forward to in my day.
Yeah.
You know, and suddenly I can't see them. It's very strange. I can't understand what's happened to me. I just can't stand the sight of those things.
And that upset him.
Initially, but then he realized the results. So, you know, but yes, he was very concerned that something's gone wrong with me.
Yeah,
you know?
But it's true. And I have to ask you this again, because food is your world and nutrition is your world. And for a lot of people, food is not nutrition. It's not, I mean, it's not just calories and it's not just nutrients, but it means so much more. It's a blanket.
It is.
You know,
culturally,
somebody who had come onto this show also said that the first thing we have is our mother's milk.
Yeah.
And so there's love, there's emotions. Now it may be good, it may be bad. You know, the idea is not to attach some kind of value to it, but it is that way for so many people. So when people come to you also, and these are things that, again, I wanted to ask you as a nutritionist, can you prescribe these drugs?
No. So I am a doctor, so I could.
Right.
But as a nutritionist, you cannot.
So not every nutritionist has a doctor's degree.
Yes, yes.
And it is
She's
imperative.
an MBBS doctor.
Yes. But not every nutritionist is.
So nutritionists are not allowed to prescribe these because these are medical drugs. So these have to be, you have to go through your endocrinologist, and I would actually say a specialized endocrinologist, not like an MBBS doctor, because I feel like an endocrinologist has spent not only 5.5 years in MBBS, after that studied a post-graduation of 3 years, an MD, and then studied a 3 more year super specialization of DM.
Right.
So I feel like they are so much better and well equipped to be able to advise exactly what the dose should be, when you should start, look through your family history, look through if it is contraindicated for you, check your reports, understand whether the side effects would work for you or not, and counsel you.
Right.
So I feel like your expert to prescribe these drugs should 120% be first with an endocrinologist.
I feel like that's not always happening.
No, it's not.
No, it's not.
And that's one of our sort of concerns.
Right.
And I agree with 100%. And even if it's not an endocrinologist, at least a senior internal medicine person. I mean, actually, if you look at the label on the pen for Mounjaro, tirzepatide, there's a red box there which says to be prescribed, taken under supervision of an endocrinologist or an internal medicine specialist.
Right.
So, quite clearly, there is a logic in saying that.
Right.
So, the reason is that you understand obesity better, you understand the nuances better, you understand the side effects better, you're not looking at it as a cosmetic thing. So I think this is the danger of the popularity of these drugs. The downside is the misuse, which is bound to happen.
No, and people are taking it by themselves.
Yes,
without,
I have many patients who first started and then they
some
got into trouble and
relative
then
has
said,
told them.
you know, I'm throwing up, I don't know what I've done, but I started. Why did you start? I said, you're a regular patient, you didn't come for 6 months, started this. Well, my friend came back from US and he said you started. So they do those kind of things.
Right.
So it's not recommended. We should strongly, through your program, discourage people from self-prescribing. Absolutely not. At least one opinion from a qualified endocrinologist will go a long way in keeping you safe.
I feel like there's two sides to this. There are some people who are perhaps not seeking the required advice and self-dosing, and then there's some people who perhaps might require this drug who, out of fear, and that might be just social media has created quite a lot of panic and anxiety and misinformation, word of mouth, and they're perhaps not exploring a very valid route to losing weight. You know, before we started rolling, you were saying you spend half your day convincing people who need the drug to take it, and then half the rest of your day convincing people who do not need it not to take it.
Absolutely. So I think the second half, the people who don't require it, is obvious. I mean, there are people who want it for cosmetic reasons, want to lose a couple of kilograms before their daughter's wedding, or want their daughter to lose that much before her wedding, all those things. And that, of course, we have to turn away. At least
Yeah.
endocrinologists will turn you away. He said, sorry, I mean, I can't do it. It's not.
Right.
But the other one is very bothersome because there are people who are ideal candidates for this,
Yes.
whose health will dramatically improve.
Yes.
And they are so scared by all the nonsense, that misinformation that's going on in the media, because there's no perspective to
Right.
it. You know, it's like saying you can't travel in India on roads because they are so bad. It's something like that, you know.
Yeah.
So the thing is that the perspective is not there, but some little anecdote or some little warning is taken up and blown out of proportion.
Yes.
So there is, if not a day goes when there is someone who is an ideal candidate, textbook candidate for the drug, and they'll say, "वो नहीं लेना दवाई."
Ji.
And I said, "You're already taking it. I mean, you're already taking previous versions of that.
Right.
We have now a better version. Why didn't you say, नहीं वो दो दवाई नहीं लेना है?" Because वो तो weight loss में बहुत side effect है.
Right.
I think the world is divided into deciding whether it's a hero or a villain. Nobody understands that it's neither. It's just a tool, and
Yes.
you need to use that tool in the right manner. You need to use it for the right people in the right way at the right dose.
Yes.
And that's what people don't understand,
Yes.
I feel.
I think because it's entered with such an explosion,
Yes,
Yeah.
yes.
and because again it is something related to losing a massive
Weight.
amount of weight, and that is something that immediately attracts a lot of attention.
Yeah.
But I just wanted to ask you, Dr. Mithal, because there were two things, side effects that you touched on which make people wary, and also the benefits that are so important. So I can ask the both of you in terms of, firstly, the benefits. Why is it that some people who struggle to lose weight, and I think you've already touched on that, find a lack of success, but then with these drugs, they find success, and that is, of course, connected to the signal that goes to the brain,
Absolutely.
which reduces your cravings. What are the benefits that one sees from taking these drugs? Because we are talking about health, and as I said, and then I want to touch a little bit on, with you, Juhi, perhaps in terms of health aside,
Okay.
people come to you to look and feel good.
Good. Yeah.
So we can talk a little bit about that.
Yeah, I mean, I think the health benefits of these drugs are quite striking, actually. It's also not clear if all the health benefits are related just to fat reduction. They may be having other benefits, other mechanisms of action.
Yes.
So let's start with diabetes, and I just gave you that patient example. Diabetes improves dramatically, and that's universal. Almost all patients who are on the correct doses with correct monitoring of these drugs, their diabetes improves dramatically.
Yes.
So that's a huge benefit. If you are struggling with your sugar and struggling with complications related to that, you'll get a lot of benefit. The second is the heart. The data on cardiac protection with semaglutide is quite strong. 20-25%, even more reduction in cardiac events, which is a big thing.
Huge.
Which is a big thing. Third is the data on kidney disease progression. So progression of kidney disease, particularly in diabetics or people who have a propensity to that kind of thing, that is clearly reduced.
Yeah.
So that's another huge thing. Fourth is fatty liver.
Yes.
Now, fatty liver is very common now. Everyone knows about fatty liver. Now
Yeah.
we call it MASLD. Forget that. But let's say just fatty liver.
And this is a lot of
Yeah.
people who look
Yeah,
relatively
yeah,
fit.
they still
It will
have
only
fatty
show
liver.
up on a blood
Blood
test.
test.
Yes. She was talking about fat
Yes,
inside.
yeah.
So fatty liver. So it's approved for treatment of fatty liver. Forget prevention. It's approved for treatment of fatty liver. So we didn't have any drugs to treat fatty liver.
Right.
So that's a huge thing. So I mean, there are numerous advantages, and then of course there are advantages linked to people feeling much better. Not all feel much better, but some feel dramatically better.
Yes.
Some of that is maybe just an action on the brain, but by and large it is because of their body image.
Yeah.
Once so many people who couldn't walk are walking now.
Yeah.
So many people who used to shun social activities are happy going out now.
Yeah.
So it's a huge boost for them.
Yeah.
And there are studies on Alzheimer's and Parkinson's, which are sort of still underway.
Yes.
So there may be brain actions also, which are
Yes.
used. So there are lots of benefits. Of blood pressure improves.
Yes.
Lot of benefits of these drugs, the
And-
medical benefits.
Dr. Juhi referred to women and the different stages that we go through. In terms of the benefits, perhaps at these stages that women might experience.
Yeah.
For example, the hormonal changes that one encounters during puberty, then post-pregnancy, perimenopause and menopause. This is the time when a lot of women would come to you.
Yeah.
I'm assuming that the weight gain that happens at this point does not put them in a category that qualifies them for a drug like this to lose weight.
Correct.
But is there ever a situation where that arises?
Yeah. Okay. So something really interesting is that the 70% of people who do come to us for weight loss, and that's a lot of people, we get a specific blood test done for them. India, we are 7 times more likely than the Western population to develop diabetes, type 2 diabetes. And our genetics, like we have someone or the other in our family who does have type 2 diabetes. So genetically, we are more prone to developing that. Now, there is something that comes before you hit type 2 diabetes or you reach that HbA1c where you are classified as someone, as a person with diabetes, which is pre-diabetes, between 5.7 to 6.4 of your 3-month blood sugar average. And there is a stage before that called insulin resistance.
Right.
And it is that insulin resistance, which is something we get tested or we send our clients to an endocrinologist or their doctor to get tested for,
Right.
to be able to understand whether that insulin resistance is something that's interfering with the rest of their hormones, because
Right.
it does have a huge role to play in PCOS.
Yes.
And because of our genetics, we could be predisposed, but eventually it is our lifestyle, which is diet and exercise, that push us over the edge to developing it and making weight loss very difficult or making weight gain very easy.
Right.
So I feel like it is those subset of people that could benefit from starting maybe one of the GLP-1 drugs, but they need to be, of course, we refer them out to an endocrinologist at
Right.
the end of the day to assess whether they would be the right candidate or not.
So two women at the same stage in their life could have different experiences with gaining weight, with an inability to lose weight because of some of these markers in their blood.
What I would say is, I'll give an analogy to explain this. So think of like 2 identical cars, and both of this person's driving these 2 cars, and both of them are accelerating at the same speed. But for one of them, the handbrakes are a little they're pulled up a little bit. So those are your hormones sort of hijacking your progress.
Right.
And that is, the people who have that normally are the ones who have insulin resistance.
Right.
And for them, weight loss becomes difficult. Their hormones go up and down. I'm not getting into the details.
Yeah.
And it is something that pushes them towards diabetes in the future. So
Right.
the correct timely action of recognizing, making them aware of it, sending them out to their endocrinologist to know that, okay, this is a condition that you should treat at this point, because 10 years down the line, it could develop into diabetes.
Mm-hmm.
And that's when, a large part of the damage to your health is already done. So we want to be able to educate them at that stage and make them realize that, okay, we need to treat the weight gain, or we need to treat these hormones for you to feel much better now and prevent diseases from touching you in the future. So that's in addition to probably helping people who come to us with diabetes and obesity. We want to prevent this for them as well.
And for people who are taking things like Ozempic and Mounjaro, then you've been able to see a noticeable change in, for example, things like PCOS.
Yes, of course. So we had, actually, I'll give you an example. I'm not going to take names, but there was a client, this young girl who came to us, and she's dropped about 30 kgs since she began the medication. And this was a while ago. It's been a year, I think, and she's been able to keep it off as well. Also,
After having stopped the
medication, after having stopped the medication, and her hormones have dramatically improved, in the sense her menstrual cycle is a lot more regular. She doesn't need to be on any other medication for it, so which is a huge win again, because you're feeling so much better. I also had someone else. I want to sort of circle back to what Dr. Mithal said about why someone feels so much better, because this was sort of eye-opening for me. She didn't have a lot of weight to lose, has been insulin resistant for a while, is aware about it. She was able to drop weight on our program, which is diet and exercise as well. But there came a time where she's like, you know what, I want to try this out. So I'm going to speak to my endocrinologist, get on the right dose. We said, all right. She tried it out, and after about a couple of months, that's when she's called me up and she's told me, you don't understand how good I feel.
Yes.
She's like, all that noise, the food noise has gone. Like, I am not constantly thinking about what I'm going to eat next. I'm not constantly hungry, irritable. I'm able to manage a healthy, nutritious diet while losing weight and feeling great.
Right.
So I have another client who's dropped 8 kgs with it, but the gut issues, gut inflammation.
We'll come to this.
Yes.
So all of that sort of pushed her back off to getting off the medication.
Yeah. So there are some people who've been,
yeah.
especially with gut sensitivities, and I will ask you because you said there are people who may not be the right criteria for this drug, and there are some who are. So if somebody comes to you who is overweight, how do you differentiate between two overweight people? One person is right for this drug and one person is not.
So can I add one point to what she said, because it's really important. People don't understand that younger people in their 20s and all with PCO who are struggling for fertility, struggling with all the stuff she said, you just can't sometimes get the weight off. I mean, they're getting depressed. Their social life is gone, their family life is gone, they're not able to find suitable partners, so to speak. I mean, all those things are happening. And use of these drugs has opened up new avenues for them. So that is quite dramatic. I completely agree with you. But there is a caveat there. The caveat is, in these patients, we don't have the correct answer as to how long to go and when to stop and what to do, because the drugs can't be taken during pregnancy. Like for us, people come to us a lot for, infertility and all this. So you give the drug and they're fantastic and they've lost weight, periods have become regular. Now, you have to stop the drug when they're planning pregnancy. So then the weight starts coming back a little bit on. We can come back to this later, but I'm just saying. So the challenge with young patients, and especially with the PCO patient, then they become pregnant, put on more weight. And then in lactation, again, they're scared to use it. So that is still an unanswered area.
Right.
So while at that point, we are clearly helping them, no question about it. But if my patients ask, what after that, I say, I don't know. We'll probably start the drug again.
No, so I can add on to that. So what we have noticed actually at the clinic is if you are eating well around this time while getting off the medicine as well, if you are taking care of your nutrition rather than just eating less while you're on the medication, you're able to combat this.
100% you're right. There's a huge difference it makes.
And build healthier habits while you're on the medication, because all the noise is gone. So that's the best time to build your healthy habits to carry it on for the future.
I will ask you about the do's and don'ts of taking the medication. But first I wanted to ask the both of you in terms of why this has suddenly become, especially when it comes to social media.
But we also haven't answered your earlier question.
Yes, and then I will come to about who is the right candidate. But because this conversation goes into so many ways, and I want to just, like social media, there are some people, a lot of them are rumors in terms of who's taking Ozempic or not. I think only one person, Oprah Winfrey, I think, has talked about it a little bit. Chrissy Teigen has talked about it a little bit.
Elon Musk.
Elon Musk has talked about it a little bit.
Serena Williams.
Serena Williams has talked about it?
Yes.
Really?
Yes.
Oh, interesting.
Yes, she said everything I did. The fittest person in the world.
Yes.
I just couldn't lose weight.
Interesting. I didn't know about that.
And
she's lost weight.
Yes. She said, I'm feeling much better. I'm good.
So why, though, has it become an obsession in the influencer and celebrity world?
So can I?
Yeah.
So I feel like, first of all, what the media paints is something we will still not know both sides of the coin, right? Like if we see celebrities taking it, we don't know whether it's just for aesthetics or whether it's for their health, because nobody is going to be vulnerable and speak about their health so openly. So I feel like we don't know which one it is. So we can't really be judging as to why they've taken it. That's number one. Second, I feel like more than understanding like why it's become so big, I feel like what we need to address is this medicine has actually changed the narrative of why weight loss is so difficult. Because if you have celebrities who have the time,
the money,
who have the access to fitness instructors, chefs, nutritionists, doctors, etc. If they're struggling and you suddenly see them lose weight, you look at this medicine as like a magic wand, and that's when I feel like the rest of the world is like, okay, how can I take it? Should I take it? I want to take it.
Right. And then it raises that whole issue about beauty and health being equitable.
Correct.
Or it's just something that you can purchase. And a lot of, my friends also sit and we say, oh, but this person can just afford to lose weight and I can't and I'm struggling. And I know again, and I will ask you about how these costs might come down. But firstly, if we just address that to people who come to you who are overweight, what differentiates one from the other in terms of being a likely candidate for a GLP-1 drug?
So the first thing we need to keep in mind is associated conditions, health conditions. Again, we're looking at health.
Yes.
Is it just weight gain or excess weight without any negative impact as yet?
Right.
Maybe it will happen in the future, but as yet, the person just is excess weight but is healthy otherwise. Good, all parameters are normal, sugar is normal, blood pressure is normal, heart testing is normal, everything is healthy, but he is struggling. So that's a different category. And the other ones are who already have health issues, like
Yes.
a fatty liver, diabetes, early diabetes, pre-diabetes as she talked about. All those things are already happening. So we are much more liberal with the second lot. Those who have associated conditions, where losing weight will get rid of that condition or help control that much better, they are clearly candidates. So even at a BMI of 27, BMI is a very crude criterion, but that's what is easy and used. So even at a body mass index or BMI of 27, if you have what we call in medical parlance comorbidities,
Right.
Yeah.
right? Everyone learnt of that during
COVID.
COVID. During COVID. So then you can be a candidate.
Right.
And everywhere there's a caveat, provided you have tried simple lifestyle measures and they haven't succeeded, and you
Right.
haven't succeeded. That is one. But if your BMI goes above 30, then you may be a candidate for these drugs even without any accompanying problems.
Right. But when I was talking to you about a friend of mine who was about 145 kilos, and you said it's interesting because these drugs are a bridge. There's some people who can lose weight with lifestyle changes, and there's some people who need surgery. And there was nothing in the middle until these drugs came along, and now there's something that may help you. But there might be people who are of a certain weight where these drugs may not actually achieve the effects that they're hoping. And for them, surgery would be the way to go?
Absolutely. So I think a bit of oversimplification, but let me say a BMI of 30 to 40, where people don't go for surgery.
Right.
These drugs are very useful. But if your BMI is over 40, drugs will still work. But if you're, let's say, 140 kilograms, you take Mounjaro,
Yes.
tirzepatide,
Yes.
and you lose, even if you lose 20% of your body, you lose 25 kilograms, let's say, you are still 115
Yes.
kilograms.
Yes.
So you really are in the category who should consider bariatric surgery. Bariatric surgery is amazing if used in the right patient in the right way.
Right.
Now the other interesting part about bariatric surgery is that our surgeons are now saying, help us prepare this patient for bariatric surgery because this guy is so heavy, the surgical risks are high. Can you make him lose 10-15 kilograms so it makes my job easier?
But how wonderful
So
that
that's
you can
fascinating.
do that.
Yeah.
It's fascinating. We had nothing
Yeah.
before. And then the other part is those who had bariatric surgery in the 90s, late 90s, that's when it really picked up in India, early 2000s, are now putting that weight back on. It's 20 years, 15 years later after bariatric, you'll tend to put on weight.
Right.
So again, don't want to go for a second surgery and they're not at that level yet or whatever. There also we're finding it very useful. So we
Yes.
work in close coordination with our bariatric surgery colleagues.
I want to come to the side effects, but before that, I just want to ask you, Dr. Juhi, if somebody comes to you and they want to take a GLP drug, what is the first thing that you would ask them?
What is the reason behind it? What are you trying to achieve? If their goal is just weight loss because they want to get there faster, or they have their expectations of weight loss are very quick, then that's a red flag. If their aim is weight loss and in addition to that, better health, as Dr. Mithal said, whether it's diabetes, whether it's managing your sugars, blood pressure, cholesterol levels, any other comorbidities, I would be like, okay, let's discuss it further.
Right.
And let's get a couple of tests done if there aren't enough, and let's send you back to your endocrinologist.
Right.
So I would say I'm not the one to advise them saying, okay, this is going to be the right path for you for sure.
Right.
I think I would try to find what Dr. Mithal is saying, the middle ground, try to understand what comorbidities, whether they're a good candidate, and then slowly, gently nudge them towards their endocrinologist to have this conversation.
Right. Again, to oversimplify, just to wrap up that part of the question, is what is the right BMI for you to take a drug like this, but it is not high enough for surgery and higher than what is required for
30 to 40.
So 30 to 40. So the side effects, I've heard a few, like nausea being one, and the reference that you made to the fact that somebody who might have issues of the gut, this medication may not be appropriate for them. So firstly, if you could tell us the side effects, and a little bit I'll ask you both in terms of how one can manage those side effects. What are the ones that at what stage should you say this drug is not for you? Because there will be a process of adjusting to the drug.
So I think it's very important in the same way as Juhi is saying that we should involve endocrinologists. It's very important to involve nutritionists in your team right from the beginning, and not when they're trying to go off the drug or something.
Yeah.
So it's very, very important because side effects are significantly attenuated with proper nutritional advice. That's crucial. So anyway, so the common side effects, these are gut hormones.
Yeah.
So the common side effects are, as we said, nausea, reflux in some people, bloating in a lot of people, sudden bouts of diarrhea, constipation. And Indians get very upset about constipation sometimes, even more than diarrhea. They get very upset about constipation. So these are known side effects. So we have handouts, for example. These are managed the common ways.
With
For
an
constipation, you
antacid
take isabgol or you take, lactulose, very normal things. But these patients should know. Like we set expectations for weight, we also have to prepare them for this.
Yes.
You're going to have some of these issues, very likely, not 100%. Some people don't even notice that they're taking them.
Is that also happens?
Yes,
Some
yes,
people do
yes.
not experience.
Yes.
Nothing at all. Nothing at all.
And they wonder whether it's working on them.
Yeah, and they say, you told me
because-
so many things, nothing has
Yeah.
happened, doc, but I said you've lost 3 kg, but I'm not feeling anything.
But are there ways to, like having it on a full stomach, or are there ways to mitigate the effects of the nausea and the
Yes,
acidity?
there are little tips that we give. We call it tips and tricks of using GLP-1s. So, for example, with GLP-1 you may not feel hungry all day, and there may be an escape from the effect for a little while, and then suddenly you may want to go sort of binge on the food. Disaster.
Yeah.
You have to have small meals,
Right.
regardless of how you feel. Important to have small meals, important to be a little physically active after meals, not vigorous, but not sink into the sofa and go to sleep, because if you're sort of upright, then you're helping your food to move a little bit better.
Right.
Right. Even water, we recommend hydration very strongly, but at one sitting, don't gulp in like several glasses of water. So these little things, and I'm sure Juhi can add more, is what my team advises people who are going on these drugs from day one,
Right.
so that they're aware. And obviously, we do recommend that eating out, reduce it. Like eating out meaning certainly don't risk street food and all for that period, because if you get a gut infection, then everything goes for a toss, because then it flares up and it becomes a complicated
Right.
issue. So we should avoid. Sometimes we use probiotics, sometimes we use laxatives depending on sometimes we use antidiarrheals
Right.
if the diarrhea is there. So those kind of things.
So symptomatically you treat them.
Symptomatically you treat. You may want to add about what you do with the diet.
So what we do when we plan, when it specifically comes to the gut, first is of course discussing the effects, side effects, what they're facing at this point in time. But the main goals or the primary treatment first needs to be that timings of meals. We need to tell them that even if you're not hungry, you need to be eating at least 3 to 4 times through the day, even if you eat small meals. Then you look at more like, I call it one-pot meals, but basically lesser volume and more nutrition.
Right.
So look, the Indian diet, khichdi,
Right.
dahi chawal, or like something just lentil soups and toast if you had to. Something that you feel that you can consume without you feeling very uneasy or bloated. Like where it doesn't look stressful to eat that plate of food, which is roti, dal, sabzi, dahi. So that additionally hydration is very important. Again, we also mentioned that you should be hydrated throughout the day, not just at one time.
But your normal amount of hydration.
Normal, not more than necessary. When it comes to bloating, there are some natural remedies we could suggest. One is ginger. Ginger does help. As Dr. Mithal said, it slows down gastric emptying. So what ginger does is it can help with nausea and also speed that up.
Right.
So it doesn't make you feel as bloated and uneasy.
Right.
These
The
are
standard
old remedies.
Yeah,
old remedies,
you
yeah.
told as
We suck on a
children,
piece of ginger when you feel
Yeah.
nauseous.
Then that ajwain jeera soft
Yes.
water, that really helps with bloating as well. When it comes to constipation, I think something that's really working well other than laxatives, and which at least I use as the first line, is a magnesium citrate tablet. So it's a supplement, and specifically the citrate
Relaxes.
salt of it will help relax and move your peristalsis. It's not going to be in that shock that it is. And constipation gets better. So just a few that I can think of at the top of my head. But switching out, let's say dahi with Greek yogurt, because again it's higher in protein.
Yes, you get more protein.
Yeah, more nutrition from it. Can I spin back into
please.
another client story?
Yes.
So this man, he was on the medication. We planned his nutrition plan, but he was just not feeling hungry through the day. So he's like, if I'm not feeling hungry, I won't eat, because if I eat less, I'll lose weight. But what happened is, at the end of the day, he would sit with a tub of ice cream and finish that. And those ill effects of eating that ice cream wouldn't show right now, because you're not eating any food.
Right.
So it would show after he would stop the medication. And that is like,
Absolutely.
the counseling comes in there.
So that's what you're saying, when you're on the medication, not when you get off it, is when you actually need somebody to tell you. And also a little bit of common sense. I think I could have even told him that's not a good idea.
Yeah, I mean, common sense, of course.
But everybody thinks eating less is equal to losing weight.
Yes.
And that is the
Yeah,
problem. You need to
yeah.
eat right, not eat less.
Yes,
Absolutely.
and that's why I think having a nutritionist is very important. Also, because people will be eating less, because if you're getting that signal to the brain that you're full, you're not eating, you're thinking you're losing weight, but you're also losing vital nutrients.
Yes.
And I think
Losing
one thing
health.
that people immediately stop eating, and anyway, I believe India is protein deficient as a country. So, protein. How can one ensure that we're getting enough such that we're not having the muscle loss, which I believe is also a side effect of taking the drug, because a whole part of weight loss is muscle loss. And I think you had said if you're losing 10 kilos, out of that, 2
or
kilos
3,
is going to
yeah,
be muscle.
may easily be muscle,
And that's
yeah.
just part and parcel of losing weight.
So the strategies we use, first, it's really important for us to understand why protein. I mean, everybody thinks of it as like, at least the population above the age of 50 that I deal with thinks of it as just an ingredient needed if you're going to the gym, or a macronutrient needed if you're going to the gym. Nobody actually realizes that it is your building block for almost all tissues in your body, whether it's your hair, skin, your nails, your digestive enzymes, other enzymes, hormones, immunity, and then muscles.
Yeah.
But it has so much other than just muscles that it does help with.
Yeah.
And if you're not consuming enough of it, because you're constantly breaking down your body's protein and it's being excreted.
Right.
So if you're not consuming or replenishing the lost amount of protein, you're not going to be able to maintain any of these tissues.
Right.
And that's when you start looking frail. That's when you start, where your hair starts falling. Your skin looks very dull. Digestion, all your gut inflammation begins. And your immunity drops.
Is this when you're on Ozempic and Mounjaro, is what they refer to as the Ozempic face and Ozempic butt?
Yes, yes.
So I think Ozempic, it's good that you brought those terms up. Basically, it means you've not followed advice.
Yeah.
There is no reason for anyone to have an Ozempic
Right.
face. Either you're losing weight too fast,
Right.
you're not taking enough protein, you're not well hydrated. Otherwise, if your skin shows the slightest signs of sagging, you can reduce your dose,
Right.
talk to your doctor,
Yeah.
adjust your diet.
Right.
I mean, so it makes no sense. But people sometimes get fixated on hitting a certain weight target,
Number.
Yes.
a number.
Yes.
And for that, they'll do anything.
Yes.
And then they look haggard and everyone says, oh, this guy has got an Ozempic face, Ozempic butt and all that.
And then they meet their target and then they want to go
Yes,
further.
yes.
Also,
Because-
I think what's important to tell them that the target shouldn't be weight. It should be body fat percentage.
Absolutely.
Right.
So you have now specialized scales at a
Yes.
lot of gyms, nutritionist clinics, doctors' clinics, hospitals, where you stand on the scale and it gives you accurately what your body composition is, whether
Yeah.
it's your fat, muscle, water, etc.
Right.
And what your aim should be is to reach an ideal body fat percentage.
Right.
So for men, between 8 to 20% is ideal. Between women, it is on the higher side, so between 21 to 33%. So it's always better to stay, let's say, for women below 30, men below 20.
Right.
That should be our goal. So if
Right.
you hit that ideal target, your likelihood of gaining weight, even after stopping the medication, reduces a lot more.
Right.
So, it's,
So, I mean, I think these body composition analyzers should be part of any program.
The regimen.
A good one should be, I mean, you cannot go on these drugs without measuring your body composition.
Yeah.
You should, your doctor or maybe you yourself should have, and none of them are very accurate, let me tell you.
Yeah.
But they are good for longitudinal follow-up.
Right.
You'll be able to say, even if the 20 and 30%, which has been mentioned and rightly, is not accurate, 19, 21,
Yeah.
it doesn't matter.
Sure.
But if you can see where you are going,
Yeah.
that's very important. And one point about diet that I was wanting to emphasize is that because there is a lot of popularity of diets that are high in fat
Right.
and high in protein. So
Yes.
while we emphasize high protein diets and high fiber, balanced fiber diets, you cannot use high fat diets when you're on this.
Right.
There's certain popular diets which are high
Yes.
fat diets. High fat diets cannot be, because you'll get a lot of reflux.
Right.
Your gastric motility is going down. So do not opt for a high fiber diet, high fat
Fat.
diet
Right.
if you're going to use these drugs.
Right.
This one.
and again, to further on in that, high protein, not always do high protein diets work. Because at the end of the day, high protein eventually still has calories, right? 1 gram of protein or 1 gram of carbohydrate, both of them have 4 kilocalories. So if you are exceeding your calorie intake while you're following a nutrition plan, whether on the medication or not,
it's not going to be effective.
It's not going to be effective.
Yeah. So the muscle loss and doing that properly, I'm assuming then strength training becomes a huge part of mitigating the effects of losing muscle mass. And is there, when you start the drug, do you have to wait before you can train? Or you can train?
No, you
should be doing it anyway.
Before,
You should be doing
anyways,
it
yeah.
anyway.
These drugs don't cause muscle loss. Muscle loss is a part of weight loss.
Right.
These drugs cause weight loss. So I just gave a talk on that 3 hours ago, that GLP-1 drugs action on bone and muscle are positive, if anything.
Right.
But the fact is that whenever you lose weight rapidly, you lose muscle also. So
Right.
now, why wasn't this discussed earlier? Because people weren't able to lose weight rapidly.
Right. Right.
So once that tool has come in, you're losing weight rapidly, you're also losing muscle. You lose muscle for the first 6 months. After that, the muscle actually improves or stabilizes, but you continue to lose fat.
Right.
So the muscle fat ratio improves at 12 months. The hand grip strength actually improved.
Right.
It's just the first study on this, but it's amazing. So we need to explain to our patients all the time that this drug is not harmful for your muscle.
Right. But which makes me also ask, then there should be a minimum period that you should be on this drug for?
Yes.
Which should be about a year?
Okay. When I talk to my patients about using this drug, and many of them come for quick fixes, and I have to explain that it doesn't work like that. I say think in years. How many years? I said we'll see.
Yeah.
But I say go in with a sort of mental makeup of 2 years at least.
Right.
But generally what is happening is we don't have that many years experience. I have about 3 years experience if I include those who had started it before it was available here.
Right.
So what we do, if patient is doing really well, then they're quite happy to remain on a very tiny dose.
Right.
And
Like microdosing?
Yes. Well, not
Not
classic microdosing, usual dosing, but the lowest level of usual
Right.
dosing. And they're able to manage quite well.
Right.
Several of my patients who lost weight with the highest dose are now on close to the lowest dose.
Right.
And maybe even given one every alternate week, which they love.
Right.
Because if you can give one less injection, they're really happy. So there are lots of strategies for that. There's a whole lot of research. In fact, one of the primary focuses of research right now is the fact that how to get off, the best way to get off the drugs.
Interesting. I will come to that, but just before that, I wanted to ask, because you've done the key do's and don'ts, the serious side effects. I know, and I can see the excitement in both of your eyes when we talk about these things, because I think you've also said in the last 40 years, this has been one of the biggest, most exciting and rewarding changes that have perhaps happened in the medical industry. And I think everybody recognizes that. But apart from the people who require surgery, some people who may not be candidates for this, or situations where you feel this might be dangerous to take. Can we touch on those?
Yes, of course. There's some are very clear cut. If you have a family history of thyroid cancer, not the usual thyroid that everyone seems to have,
Yes.
thyroid cancer, particularly medullary thyroid cancer. It's a rare type of thyroid cancer. So then you're not a great candidate. You should stay off it. If you have a history of pancreatitis, while the evidence in humans that these drugs are causing either the thyroid cancer or even the pancreatitis is very flimsy, still there is an action on the pancreas, so you want to be super cautious. So if you have a history of pancreatitis, don't go for these drugs, right? Personally, I'm also very cautious in those who have major gastrointestinal issues initially. It's not smart. I mean, again, common sense.
Right.
Why would you
Put yourself through that.
use a drug like that? So these are people who are not great candidates. In addition to that, people who have active eye disease, active retinopathy, diabetics.
I did read somewhere about blindness.
Yes, we'll come to that.
Yeah.
So one is the one that is known for a long time. That is, if you have active retinopathy,
Right.
It's a complication of diabetes, active retinopathy, and proliferative retinopathy, then you're not a candidate. Now this has been known for all these three apply to all the predecessors of these drugs they've been using for 20 years.
Right.
Nothing new in that. Now the one that is the only one that has emerged unexpected is still questionable. A lot of data showing it doesn't happen, some showing it does happen, but you always flag something when you hear something, and that is a kind of optic neuropathy.
Right.
Right? Non-ischemic arthritic. So, non-arthritic ischemic optic neuropathy. So, that is not a great thing to have.
Right.
Because that can cause vision loss.
Right.
And sometimes it may not respond very well.
Right.
So, how should we? First, we have to understand that is exceedingly rare,
Right.
if at all.
Right.
Because there are equal number of studies saying it doesn't happen.
Right.
Number one. Number two, there is the issue of at least getting a proper ophthalmic exam before you start. Now, we don't know the benefit of that exam. There is no longitudinal study to say that those who had a good exam were able to prevent it, all those. But we
Right.
don't. But intuitively, again, common
Right.
sense, if someone already has changes, it's a rare condition, maybe that person has it already.
Yeah.
Or is beginning to have it. So then you don't start the drug.
Right.
So I think an ophthalmic exam for diabetics is a no-brainer. You always
Yes.
need to have that.
Yes.
Even for non-diabetics, and again sticking my neck out, it's not part of a protocol, but I do think that it may be sensible to have it till we understand more about this Nion business,
Ji.
and then maybe we won't need it, but at the moment it's probably just safer. There are certain signs in the retina or near the optic nerve that tell you maybe he's a little bit more prone, then you may want to avoid it.
Right. But the link that people are drawing to these drugs perhaps in the future, because also there seems to be a sense that these drugs have not been studied for long enough, and I will come to that because you've already referred to that in your book, that we do know it for about 20, 30 years. And they've been in clinical use since 2005, which is enough to say that they're safe. But what I want to take away is that there are risks in any drug.
Yes.
There's no drug that has been invented that doesn't have a risk, including aspirin, very safe drug that lots of people use. So just because there are risks that you're required to list out should not scare you.
Absolutely, I totally agree with you. But patients need to understand it's a drug. People need to understand it's a drug.
Yeah.
Should be taken under medical supervision. Ad nauseum, I'm saying that, sorry, but
Yes.
that's the right thing.
Yes.
Yeah.
And like with every drug, and I give the aspirin example, often people understand it.
Yeah.
People are popping aspirin for their prevention of their heart condition or just for pain, and they take painkillers like
Yeah.
anything
Yeah.
without worrying about the kidney.
Yeah.
So every drug when used inappropriately can have side effects, and rarely, even when used absolutely correctly,
Yes.
no one can say
Yes.
100%. Our professors used to say, never say never and never say always in medicine.
Yeah, because you'll get sued.
So, because that's not correct.
Yeah, that's true. From a nutrition standpoint, I just wanted to
Yeah.
come to you and
Yeah.
also to ask you about certain case studies that you
Yeah.
might have come across in terms of things that have worked or not worked, things that might have excited you most,
Yeah.
perhaps, one of the stories that you feel this is why
Yeah.
I enjoy doing this, or something that didn't work out the way that you expected to work out.
Yeah.
And then from a nutritionist point, because I feel like a lot of Indian diets are very carb heavy.
Yeah.
For example, roti and rice are staples. So when somebody starts a GLP-1 drug, do they have to rearrange their plate? And how would you do that?
You should already be rearranging your plate before you started, but yes, I'll come to it. I wanted to quickly just talk about two more contraindications I feel that
Yes.
should be on this as well, which is anyone with eating disorders. I mean, it's a no-brainer again, but eating disorders, which are hard to understand when you're speaking to the patient.
Yeah.
So spending some time digging into why they want to take it is important, and their eating habits prior. Also, women with hypothalamic amenorrhea, I feel, should not be on this. Hypothalamic amenorrhea basically means women who have not been getting their period.
Okay.
And that could be because of undereating, and that because of which, like undereating fat, because of which their hormones are not working the way that they should, and that's why they lose their period. So putting them on a medication like this would possibly be more detrimental than good.
And the eating disorders you're referring to, you're saying that because there's a complicated relationship
With
food.
Yes.
And this drug might trigger what?
Dependence.
And eating disorders also switch,
Yeah, yeah.
You can go from one extreme to the other.
To binge eating, to anorexia.
And they use these drugs, you may trigger off. So
Right.
Should not.
Yes.
Right.
Coming back to your question, yes, when it comes to protein, when we plan a nutrition plan for someone, the normal recommended daily intake is about 0.85 to 0.9 grams per kg of body weight. What we use for our clients is we push it up to between 1 to 1.5 grams per kg of body weight protein for them. And that is primarily to preserve the muscle mass. Secondly, what I would say when you need to rearrange your plate is you need to look at it as 50% protein. The rest can be fiber and carbs.
Right.
Because if you're going to focus just on the foods that are making you feel better at that point in time, which is going to be lesser protein, in the long run, that's going to affect your health. When it comes to clients, there was one client that I feel like I want to discuss. He came to us many years ago, above 120 kgs, and tried to lose weight with us, and was also advised bariatric surgery. Decided, okay, no, I'm going to try, give it one shot. And he started falling into the pattern of feeling low, avoiding social interactions, not enjoying, like having a low mood altogether.
Yeah.
Even though he was on the program, because his weight loss was slow and fluctuating, because his life demanded him to be out, like traveling a lot or eating out a lot. So after a couple of years, he came back. We spoke to him, advised him to visit his endocrinologist, especially since this had come back about a year ago. He went back and was started on Mounjaro. Was started on Mounjaro. And since then, instead of him meeting me on a weekly or once in 2 weeks basis, he comes once a month. He's very happy with his progress. He's enjoying his food. He's building those sustainable habits and enjoying them at the same time.
Right.
Because that noise is not there around food. And he's able to portion his plate without feeling overwhelmed or feeling like he has that fear of missing out on that certain food that he wants to eat.
Right.
And he's enjoying his exercise. And I think that's also key, because when you build that habit while you're taking this medication, that is the biggest gift you can give to yourself for the long run. So when we consult a client, we don't tell them you need to exercise to lose weight. We tell them you need to exercise for your long-term well-being.
Right.
If you want to take care of your knees, you want to take care of your heart, you want to take care of your kidneys, your brain, every single thing requires you to exercise regularly.
Yes.
And if you're able to build that habit during this time, because you don't feel that lethargy anymore, I think that's the biggest win.
Yes.
So with him, that was amazing.
Yeah.
And I feel like his win becomes our win when we meet them more often. And we keep seeing his progress in terms of muscle mass, and it's just, touch wood, surprisingly, as Dr. Mithal said, it had dropped in the beginning and then it's been going up.
Yeah.
Which is amazing.
Which is wonderful.
Yeah.
I think, coming off it becomes a concern for a lot of people.
Yeah.
Because they say, and that again, the noise is that the minute you come off it, the weight comes back. And I wanted to ask you, how does one come off it in a way that you can keep the weight off?
So, as I was saying, this is the primary focus of research now. Large studies are ongoing. But the first thing we have to understand is, if you're thinking of obesity as a health condition, think of diabetes as a health condition.
Yes.
If you think of blood pressure, fatty liver, even sleep apnea.
Yes,
that we forgot to talk about that. Yeah. I mean, diabetes requires lifelong treatment, right?
Yeah.
Blood pressure requires lifelong treatment.
Right.
So at some conceptual level, the drugs will work only as long as you take them.
Right.
That's the harsh reality. So it's not that how long you have to take it. People often, when we start diabetes medicine, even then they ask the same question.
Right.
But then they gradually understand that you really can't go off the medicine. So those who have considerable comorbidities along with this, multiple other, they will remain on the drug as they were on their predecessor drugs. They'll continue to have it for diabetes. I mean, if we are having the once weekly dulaglutide or liraglutide, you would continue to have it. I mean, you're not asking me. Now, what is the problem there in having it? Because you're concerned about long-term side effects.
I mean, just if somebody says you have to take this for the rest of your life.
We never say that initially, because we don't know. And if you say that, you're ensuring the patient will never start it.
Right.
So their perspective changes when they use the drug.
Right,
Yeah.
right.
Some of them need it for all their life. So as I'm saying, someone who has all these multiple comorbidities is likely to need it. What are they scared of? They're scared
They just
of
want you to,
long-term.
we want you to tell us that it is safe to take for the rest of your life.
So it can be safe. You have to maybe adjust the dose. You don't want weight loss all the time.
Yeah.
You're using it for other benefits. So reduce the dose so that you're not producing much weight loss.
Right.
So it can be used, yes, number one. Number two, is the young patients I talked about, where it's a challenge. The very elderly, where there's already muscle mass loss, that's
Yes.
also a challenge. So at the moment, the strategy is to really focus on the diet, exercise, sleep, and other lifestyle measures from the beginning.
Right.
Use this as an opportunity to correct your lifestyle,
Yes.
which you were not able to.
Yes.
They're giving you assistance to do that.
Yeah.
So that by the time you're coming off it, we're thinking of bringing you off it, you have well tuned to it.
Yes.
Having said that, it is true that most people will put on some weight when you try to take them off.
Right.
So the current strategy for those who are in the significantly overweight zone or obese zone is to maintain them on very low doses.
Right.
And many of them will succeed with that.
Right.
And as we get more and more research, we'll know, that what proportion of people can be taken off.
Right.
We don't have those figures yet.
And typically, if somebody's taking it once a week, then you could increase the gap.
Yes, we
and
could
reduce the
sometimes
dose.
increase the gap. Also, that strategy is also being looked at and has shown some encouraging results.
Right.
But, again, the fundamental truth that people have to remember is that every drug works for as long as you use it.
Right.
So it's not like an antibiotic,
Right.
which you're killing the infection and
Right.
sending it away. It's a chronic condition. You will need the drug for
But
a
it's
longer period.
an opportunity, certainly.
Yes.
And I think what was interesting, I think we were discussing it off camera, was keeping a diary, which I thought was
Yes.
very valuable, which you said, which is just what you are doing while
Yes.
you're on the drug.
Yes.
Try and
Yeah.
continue doing
Yes.
for the rest of your life. And that would also be helpful. Microdosing is something that people are referring to now in parties. And they're saying, when I come off the drug, then I will microdose. And that's how I'll maintain my new weight.
I don't think there are any guidelines for microdosing,
Yeah.
but I think Dr. Mithal would be the best to answer this question, as of what I know. However, I know some of my clients who have said they tried microdosing and it worked for them.
Yes.
So,
So exactly same answer.
Yeah.
That we don't know yet because we don't have trials. Microdosing is not recommended.
Okay.
If you ask me medically, it's not recommended. But I do have some patients who have done that without my knowledge, and actually they're doing okay. So
Right.
I think we require data, and I'm sure, I'm not directly aware of a study, but I'm sure this will be a subject for a very active study right now.
Right.
And maybe it is true that some people see when you're using microdosing for maintenance, that part will be figured out
Yes.
earlier.
Yeah, you'll see. If
But
it's
when
big,
you're
it's
using
okay.
microdosing for losing a couple of kilograms, that I think is a bit of a grey
Yeah,
area.
yeah.
We wouldn't recommend.
Right.
We wouldn't recommend.
The safety element also refers to the fact that people feel that has this drug been studied for long enough.
Yes.
And I know that you've referred to it in your book, but if you could just tell it for our audience in terms of whether it's been covered for long enough for you to say that it is safe.
So, see, we are still discovering or at least assessing or discussing potential side effects of metformin.
Right.
Yeah.
Metformin in 60 years. So these things will happen when you use medications. Like in food, every day you hear something new.
Yeah.
That this is good for you, this is bad for you, this you can't have. Suddenly
Often
everyone
you hear the
discovered
opposite
magnesium.
also the
We
next
never
day.
talked about magnesium
No.
10 years ago.
No.
Yeah.
So these things will happen.
Right.
So that's number one. Some little things may emerge after a long time.
Right.
We're still not sure where to give aspirin, where not
Right.
for blood thinning. That controversy is always on. So similarly, for these drugs, I think the predecessors of these drugs have been in clinical use since 2005.
Right.
Which means they've been studied for at least 10 years earlier, so 90s, maybe even late 80s. So that's since then they've been under study. The difference, of course, is that these drugs are more potent for weight loss. Even then, semaglutide was approved by the US FDA in 2018, I think. That's already 8 years.
Yes.
And Mounjaro are 3 years later, probably.
Right.
So I think this semaglutide and tirzepatide, of course, no one can rule out that you'll find out something 20 years later, but that's true of all the medicines that you take.
Ji.
But drugs are not licensed so easily. They are not made part of a WHO essential drug list. They're not talked of reducing prices worldwide.
Right.
The President of the United States is saying he's going to slash the prices.
Right.
I mean, and even in Africa, I mean, there's so many attempts to make them accessible to more people.
Right.
So that only happens when the benefits far outweigh the risks.
Right.
So that's how we have to look at it.
I do want to talk a little bit about the price because a lot of people say that this is relatively expensive as a way of losing weight. And then there's a whole discussion what we were referring to earlier in terms of this creating inequity in the world. One thing is that we can look forward to the prices coming down, but can you just highlight for us what the current prices approximately are. I'm assuming they're about 20,000 rupees a month.
So I think the lower dose is around 12. It's come down, I think, to almost 10 now.
Yeah.
So, and the higher dose is around 20, 22. So they're expensive. But this, when we say this figure, it's per month,
Yes,
not per
per
injection. Not per
Yeah.
injection. So you can say 12 to 20,000 per month is the current cost.
It used to be the cost per injection maybe 2 years ago.
Yeah,
So
yeah,
it's
people
come
were
down
getting-
by
oh,
come
then
down
that was even higher.
Yeah,
It's
yeah,
crazy.
yeah.
People were still.
And these costs are
certain-
because these are patented drugs.
Yes. Now you cannot really fight about the costs.
No.
Till the parent company brings down the cost, if they have a patent, they will use it. It's for them. It's also a business,
Yes.
and they have to invest more in their research and do whatever.
And it's a
Farmers have
capitalistic.
their own
yeah.
ways. Yeah, I mean,
Yeah.
Now the truth is, however, that injectable semaglutide has, as I said, caught the eye of the WHO and all the governments. Plus, the patent is in India is due to expire in March or April.
Right.
And people even told me 22nd March or some, drug companies. And I know for sure.
So there are people waiting.
Yeah. So I know for sure that we'll have at least half a dozen Indian companies
Who are ready
which
to
will
go.
flood them. They're just waiting for a yes from the government and they're ready to go.
So 22nd March is what they're waiting
yes. So I think and I don't know the price they're going to come out with,
Yeah.
but it'll be less than half for
Yes.
sure.
Yeah.
Definitely less than half.
Yeah.
So I think there is these things happen. We should not get frustrated about the prices. In this environment of drug discovery, when drugs come out for the first time, every drug you're using now, simple drugs, even the glargine, insulin, or sitagliptin, or dapagliflozin, commonly used drugs in diabetes, were out of reach of most of our patients.
Right.
And now they're within reach of almost everybody.
Right.
They're even part of the Prime Minister's Jan Aushadhi program.
Right.
So fantastic. So this is a matter of time. So
And
you need to-
as you said, like for example, I think the NHS has already brought these drugs
Yeah,
under its umbrella.
Yeah.
We can look forward to
Yes.
these being more accessible,
Yes.
and therefore
I'm
perhaps
covered.
certain they'll become more accessible. Yeah.
And do you think that they'll come under insurance and things?
Well, in India, that's a challenge because outpatient insurance is very
Yes.
weak here.
Yeah.
We don't pay for prevention of heart attacks, but we pay for the heart attack.
Yeah.
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 So that is
Yeah.
a strange system. But
Right.
those who have OPD coverage, outpatient coverage,
Yes.
would
They'll have
I'm
that.
sure they'll be covered.
I just want to talk, as we come towards the end of this, a little bit about people who want to try and lose weight without the medication. How do you advise them to do that best?
Okay, so are we speaking about the people who don't want to be on the medication at all?
And we can
Break it
talk
up
about
into two
both,
parts.
but
Okay.
let's talk about first about people who have now come off the drugs and they want to lose weight, not on the drugs.
So we both have multiple times we've mentioned how protein is really important and how your muscle mass is really important. So the most metabolic tissue in your body is your muscle.
Yes.
That means it's being able to utilize whatever food you are eating to be able to break it down and create energy
Yes.
from it. And if you do not have enough muscle in your body in the long run, your metabolic health suffers and your metabolism starts to drop. So if you do not preserve your muscle during the time you're on this medication, after you get off the medication, you will not be able to keep the weight off.
Right.
And this is the same thing that holds true for any weight loss program.
Yes.
It doesn't just mean it's for Mounjaro or Ozempic. It's for any weight loss program. If you're on a crash diet during which you lose a lot of muscle, you're not going to be able to keep that weight off.
Yeah.
It's as simple. So I think that is your key to managing your weight after getting off this medication. And I do believe that there are a set of people, the same way the younger population at least, how they start metformin for prevention, and then as soon as they reach their ideal body weight or their ideal body fat percentage, they're able to get off the metformin. There could be maybe an opportunity in the future where
For some people who don't know what metformin is, can you just tell them a little bit?
so it's the first line of treatment for diabetes, type 2 diabetes, but it can also be used for treating insulin resistance. The aim of metformin is as an insulin sensitizer. That means your body needs to be able to, insulin as a hormone is used to shift your glucose, which is your blood glucose, into your tissues. That's its main role. If there is a block in the action by your own body due to high body fat, genetics, unhealthy lifestyle, etc., this block in action would not allow the glucose from shifting from your blood into your tissue. And you require an additional, your brain thinks that there's not enough insulin, so it tells your pancreas to secrete a lot more.
Right.
And when that excess insulin comes into your body, that's what creates the havoc, where it leads to suddenly opening the floodgates, allowing the large amount of glucose to enter, and that's why you end up developing more body fat rather than using that food or the energy you have consumed to be used up for energy instead of
I understand.
yeah. And metformin treats just that.
Yeah.
So it fixes that block in action.
Yeah. I want, because it's called All About Her, and we did refer to various issues and various times when women put on weight. Again, a friend of mine who had a baby and of course has put on perhaps a little bit more weight than she wanted to. Breastfeeding, when she comes off the feeding, would she be a candidate for a GLP-1 drug?
Well, there's nothing against it, but again we'll have to map out some plan for her.
Right.
We'll have to map out some, but otherwise yes. If she's not breastfeeding and she's overweight and the obesity is in a zone which fulfills the criteria we are talking about, then she could be a candidate, of course.
Do a lot of people come to you postpartum?
Yes, but very few people have actually asked about GLPs during
You're
that time.
absolutely right.
Yeah, very few people postpartum, because I feel that during the time you're breastfeeding, your body's metabolism, like you're requiring a lot more energy. So I feel like they're able to bounce back pretty quickly.
Does it affect your hormones? And I know that it has a positive effect on fertility because a lot of infertility is linked to obesity, but does it have any side effects in terms of your hormones? I know you said that women who don't get their periods perhaps should not be taking it. But for somebody who's getting their periods, but as you said, our hormones go up and down, thyroid, insulin, PCOS, all these things come into play.
So I would say the people who develop any gut issues or gut inflammation during this time could then develop like a hypothyroidism, or could have a skewed thyroid, or their hormones go up and down, which could be a result of your body not being able to absorb the nutrients from the food you're eating, whether it's B12, whether it's zinc, whether it's iron, selenium, to name a few. So if your body is not being able to absorb those nutrients and your body is deficient in them, that could affect the making of your thyroid hormones, which would then affect your metabolism.
Right.
It's a very nuanced, like it's not something that's going to be loud on your blood report.
Yeah.
But it's something that we need to understand when we speak to the client.
Even perimenopause, because that's something that is personal to me, and annoying weight gain that happens around then. Do people come to you for that?
Yes, actually a lot. Yeah.
In that, I mean, I feel like your 40s is an age where things start to stagnate.
Metabolism.
Yes. And a lot of people struggle with that. So if done properly again, I'm assuming that the criteria is met. Your BMI.
So one little point again about the period. It's not that people who don't have periods can't use it. A particular kind of amenorrhea she was talking about.
Yes, there are people who are not getting their periods at all. Yes.
Yeah, that's common. That's not common.
Not the PCOS kind of menstrual cycle loss.
I just wanted to ask you philosophically, the both of you, in terms of the idea of, I know that you're very deeply talk about the health benefits of these drugs, but they do come hand in hand with a beauty image. And I just wanted to ask you your thoughts philosophically in terms of whether you think that these drugs, not what they've intended, in that the intent was something else altogether, but one wonderful side effect is that people lose weight, and now that has become a primary focus for the drug. But do you think it reinforces any kind of negative beauty stereotype in the way that it's being used or in the way that people are taking it?
I think it's more in the way people are taking it rather than the way it's being used, because I feel like doctors are using it correctly, but the way that people are looking at social media or reading things online, the way that their narrative about the drug is wrong. You need to change the narrative back to health rather than weight, just as you said.
How would one do that?
This.
Keep saying the right stuff as you are doing.
Right.
I mean, that's the whole thing.
Right.
Also, I mean, this body image issues are a big issue now. They always were, but with social media being so influential and so many influencers, and you don't even know if the image is sort of
authentic,
AI generated or whatever, and so people start craving or hoping or aspiring to have bodies like they see on that.
Yes.
They want to be like that. those are challenges of the modern world. I mean, and they're often totally unrealistic.
Yes.
But
I do believe in India. I feel like society does judge a lot more in India as compared to the Western world. A friend had recently told me when she lived in London, she didn't feel as judged if she was overweight. But the moment you come to India, you're like, whether you're eating your meal, walking on the street, whatever you're doing, there are always eyes on you and people are judging that, oh God, she's overweight.
Yeah, why is that?
She must be...
I think culturally we are tuned to getting into others' lives. You live in Bombay, maybe you don't realize it so much. But culturally we are all, we don't look at what we are doing, we are more concerned what the other person
and we're comparing ourselves to other people. And we're very tactile. We like to touch and feel and comment on people's appearances all the time.
Yes.
I'm saying we, but I don't mean we. I mean, you like to do that. The other thing that maybe I feel like you want people to shed is the stigma. Because I said it's difficult. And you said that a lot of men are happier to talk about their journeys with Ozempic. This book is peppered with testimonials.
Yes.
And a lot of them are from men who are happy using their names, but a lot of the women did not want their names to be used. We found it hard to find a woman to come and talk about her journey today. So this stigma of I'm on Ozempic, if somebody could actually come and authentically tell their story and how it helped them, how can we shed that also?
It's a matter of time.
Yeah.
It's a matter of time, so I think it'll go away.
But I also think it's the right information. Right now there's so much misinformation where the world is divided back to thinking either Ozempic or Mounjaro. GLP-1s are heroes or they're villains.
Yes.
They're not understanding the fact that it's just a tool to get you where you need to.
Yeah. And I think if you could
if you do it right, you're
Yes.
not going to come in the eye of anybody. Like no one's going to look at you and say, oh my God, you have the Ozempic face.
Right. Last couple of questions, maybe for you, like the key do's and don'ts for people who are on GLP-1 drugs, if you could just highlight. And then I wanted to ask you, Dr. Mithal, about the future and what you see in terms of, there was a reference to oral pills, for example.
Yes.
So first, perhaps some basic do's and don'ts that you would encourage people.
First, follow up with your doctor, because I feel like when you start getting the symptoms of the gastric distress, they don't go back to their doctor. They say, I'm going to just stop it on my own.
Yes.
And what your doctor could actually do is bring your dose down to something that's acceptable to you, or stop it altogether for you because they realize it's not working for you and give you another solution. That is number one. Second, I would say that protein, very important. Taking care of your gut, taking the right kind of multivitamins and the vitamins that you would possibly not be getting enough if your gut is not okay. Need to supplement with that. Hydration, exercise is key. And the intent with which you're taking, you need to reassess the intent with which you're taking this medication. Yeah. Your intent needs to be right, your expectations need to be right, and your support needs to be good, where you have a doctor, your family, and friends, whoever's close to you, and you have a nutritionist on your panel.
Lovely, wonderful. The future of obesity treatment for you, Dr. Mithal.
So I think these two molecules have actually opened up a whole new path, like their predecessors did for these two.
Yes.
Now scientists are more and more ambitious and doing all kinds of stuff. So the first thing that will happen is that you'll have oral pills probably this year.
Really?
Yes. Which will be almost as effective as the injectables.
And the injectables are tough for some people who are scared of needles.
And some may prefer oral, some may prefer injectable, so that's okay. But oral pills will be there. Initially, there will be oral pills that are to be taken on an empty stomach and nothing after that, etc. But subsequently, there might be pills where all these restrictions don't apply. So oral is one big area. There may be injections that have to be taken less frequently.
Right.
So less than even once a week. There may be other drugs that may help preserve the muscle while you're on these drugs.
Right.
So multiple approaches will be there, and not the same drug won't be the right drug for everybody. Then we'll be talking a very nuanced approach, who goes to what molecule.
Right.
And I think the most exciting for people to hear is, of course, because it's about weight loss, is the fact that you have a triple receptor agonist in the making, and even more than that, but triple receptor agonist is already tried.
Right.
It is called retatrutide, and retatrutide will be used, I think will be in use very soon.
And just explain, triple receptor means that then now these have been double receptors,
So,
the Mounjaro.
So GLP-1 semaglutide, acts through GLP-1 pathway. Dual receptor, tirzepatide
Yes.
or Mounjaro, acts through GLP-1 and GIP. There is another dual receptor, another of a different kind, which is glucagon and GLP-1.
Right.
And then there is a triple receptor,
Right.
which acts through 3 pathways.
Right.
So retatrutide,
Right.
so which has already been tried,
Right.
and that actually produces weight loss of maybe 25%.
Right.
So it's mind-boggling. I mean, these things would be considered unimaginable 10 years
Absolutely.
ago.
Yeah.
So we are in for very interesting times, and our patients will have a lot of choices. We'll all have more choices, so that if one doesn't suit you, one doesn't work for you, you have other options. So this is not going to go away.
Yeah.
This is going to be there, and newer molecules are going to come.
Lovely. I'm so glad I had the both of you, because I really do feel, and especially after this conversation, that a nutritionist, an endocrinologist, and all the knowledge that both of you have are both very important ingredients for somebody who's starting their weight loss journey through GLP-1 drugs. So thank you both for taking the time and for being on the show.
Thank you for having us.
Thank you.
Thank you.
Thank you. Great discussion.
Thank you. So I think my takeaway from today's discussion has been that Ozempic and Mounjaro are definitely not some kind of miracle drug, and they're not to be used as shortcuts. They are medical tools, like Dr. Juhi said, and like all medical tools, they need context, they need caution, and they definitely need the right guidance. For some people, these drugs can be genuinely life-changing, and for others, they may not be appropriate at all. What matters is understanding that obesity is a complex medical condition, not a moral failing, and that no medication really works in isolation. And I think the basic fundamental building blocks of wellness remain to be your exercise, your sleep, and your nutrition. Weight loss is not just about what you take, but it's also about how you eat, how you move, how you manage stress, and how consistently you care for your health over time. So if there's one takeaway from today, it's this. Please do not make health decisions based on trends or on social media timelines. Have informed conversations. Ask questions. Seek professional advice. A big thank you to Dr. Mithal and to Dr. Juhi for bringing science and clarity to a very important conversation, because the goal is not just to lose weight, it's to gain health. Thank you, and until next time, stay informed, stay healthy, and we will see you in the next episode.